Our next speaker this morning is Dr. Alfredo Moravia. He is the principal investigator of the ongoing World Trade Center Heart Cohort Study funded by NIOSH, and he's leading the research and examining the long-term effects of the 9/11 attack on heart health of first responders. Please welcome Dr. Moravia.
Good morning, everybody. It's my pleasure to talk to you about the work we've been doing since 2012. Many of my colleagues are in the room or on Zoom, and I'll introduce them to you at the end of the presentation. So the idea in 2012-13 was to carve within the World Trade Center Health Program a cohort to study cardiovascular outcome. And in order to study cardiovascular outcome, we need to have measured classical cardiovascular risk factors. So we need to measure blood pressure, measure weight and height, measure waist circumference. And for this, we also needed to have a standard assessment. So we recruited the cohort at Mount Sinai in the waiting section where people were going to get to their visit. But before that, we had trained all the people, the physician in particular, and nurses at the health program in order for them to be able to do those measures in a standard fashion. And I think this is key for a cardiovascular disease, a cardiovascular epi cohort, because otherwise everything that is self-reported is considered as of poor validity. So we recruited in 2012 and 13, over 18 months, 6,500 people in the World Trade Health Program, and we actually got all those measurements for which also we had bought all the equipment. So we think we got measured classic conventional cardiovascular risk factor on all of them, collected in a relatively standard way. So from then, and this is we have had free grants. The two first are about the first part of the study, which I'm going to summarize, and the third is ongoing work, and I'll tell you what we're trying to do with our new cohort. So in this, in the first part, we studied, so we recruited in 2012-13, and we followed up until 2016. And we had two types of follow-up. One was an active follow-up, so we have a group of interviewers who contact all the participants every year and obtain from them information about whether they had cardiovascular outcome, and specifically heart attacks or stroke. And this was one form, and then when the participant tells us that there has been an event and they've been hospitalized or seen by a doctor, we try to obtain the medical charts in order to validate the event. We found about 100 cases over those 4 years this way. But we had also a passive linkage with SPARCS, which is this database for New York States that records all hospitalization, and we found 150 cases there. So there were 50 additional cases that we hadn't found with our active follow-up. So on this basis, we ran this analysis. Here you have a survival analysis with the risk in people with PTSD in the bottom and non-PTSD on the top. PTSD was actually the main risk factor that came out from our analysis. The other factor that was associated with cardiovascular disease was smoking. All the other factors didn't come out, and there was no association with dust, which was one of our earlier hypotheses. But as you know, the measurement of dust for this cohort has lots of problems. So dust exposure. So we didn't find any type of relationship. So in this, you find essentially our main differences. This is for all MI and stroke in all our participants, and you see that there was about a twofold difference, an increased risk of cardiovascular outcome among people who had probable PTSD. And when we looked in more detail, of course, with 100 cases, our power was statistical power was relatively limited, but we have men and we have women, which is relatively rare in those types of studies because a lot of them have been done strictly among men. And we have MI and stroke, and both of them. And this is what we could look at in terms of outcome. We will be able now to look in more detailed outcome. But this is the categories we used. You have PTSD here, no PTSD. You have the hazard ratio and the adjusted hazard ratio for all conventional cardiovascular risk factor. And this is, the forest plot, and the bar here, the line, the dotted line is 1 if the interval, the confidence interval around the estimate crosses that bar, is said non-statistically significant. And you see that for men, we had about a twofold increase of MI, of stroke, and of both, which was very clear, even though we had relatively small numbers. In women, which was really interesting, the estimates were of similar magnitude, about 2. But given the number of cases we had, the precision was very low, and so they didn't come out as statistically significant in none of those cases. But the fact that both men and women seems to have the same type of association between having probable PTSD and having those cardiovascular outcome is in itself a very important finding and relatively unique. And then if you look at all the outcome, of course, it's stronger. So we also looked at the association after eliminating the people that had eliminating, not exactly that, but not analyzing, not including in the analysis people with depression. And we still found the association with PTSD. So this was with about 100 cases, recruited by active follow-up, and this is with more cases, 150 from the linkage with Sparks. And you see that the results are, again, extremely consistent. Hospitalization or active follow-up. And the data on the active follow-up are not the validated one, but the validation was relatively good on our on the people that we were able to follow and obtain the medical charts from. And all the medical charts were read by 2 people, 2 MDs, and we agreed upon the final diagnosis. But this is hospitalization, and you see in men, again, about a twofold increase, and the adjustment, as you see, doesn't change much. Even for smoking is included in this adjustment. Interestingly, in women, now that we had a little bit more power, the hazard ratio for both MI and stroke was borderline significant. So confirming what we had in the other. And then when we group everything, the results are quite consistent. So these were our major findings. I think those results have lots of weight in systematic reviews, and essentially all the studies tend to confirm that there seems to be about a twofold increase between PTSD and cardiovascular disease. So now the problem here is that the association between, why isn't PTSD recognized already as a conventional risk factor? Why isn't it integrated as hypertension, diabetes, obesity, smoking, as a recognized cardiovascular risk factor? And that's the problem that we have tried to address in our current study, which is ongoing. We are at the second year. We're collecting the data. But we have tried in this one to assess the causal effect of PTSD. And this is a key element here, and on the symptom burden is the other key element. So what's the problem? The problem is that you have PTSD, you have cardiovascular risk factors. Okay, we know those cardiovascular risk factors are associated with increased CVD, but how is PTSD acting? Is PTSD increasing those conventional risk factors? And so it's not a risk factor in itself. It just is, its impact is mediated by the impact of PTSD on having people smoke more or have higher blood pressure, etc. Or is it an individual effect, a direct effect of PTSD through the neurologic system, changes in hormones and other biological characteristics that in itself would increase atherosclerosis and produce heart disease. And because there is this ambiguity, and we cannot separate whether PTSD is an independent risk factor or is just its effect on heart disease that we show here is mediated by conventional risk factor. That's the question we try to analyze here. So what have we proposed and what are we doing? In 2012, we had one baseline, right? 2012, 2013, one baseline assessment. As you know, there is the risk period. We had CVD, the outcome, and we have the cardiovascular risk factor. So this analysis, we cannot say whether the risk factors are mediators or are confounders. It's extremely difficult to separate, even if you use sophisticated approaches. They are extremely correlated. So what we've done now is that we are doing a second baseline so that we will have two baseline and the same situation repeated twice, but now PTSD is going to be once, a confounding for the association, the risk factor are going to be now a confounding for PTSD. And in the second, from baseline 2 to CVD is going to be more of a mediator. And so by having two baseline, we will be able to separate the mediation or the confounding effect of the cardiovascular risk factor. And that's what we're currently doing. We have retrained our colleagues at Mount Sinai and in Long Island. And we are asking all our participants to undergo a new visit where they will have a new measurement of those specific cardiovascular risk factor. So that's one way we want to approach the problem. The other way is that you can separate the effect of CVD, risk factor, and PTSD if you have multiple measurements, because then you have trends, and you relate those trends with the outcome. And the trends, they may actually show that they are not, parallel, and so that you can separate what is the impact on CVD from one factor to the other. And in order to have those trends, we are developing a measure which is a symptom, PTSD symptom burden, where we accumulate the reports on CVDs at all the on PTSD, excuse me, at all the visits, and this accumulation may also give us an idea of when you treat PTSD and you can reduce the PTSD score from one level to the other, what's the potential impact of this on the CVD risk? This would be, we would need a randomized trial to really test this, but there's no possibility of such a trial with an outcome such as CVD. There have been small trials with symptoms or cardiovascular risk factors as outcome, but an equivalent to this cohort would be extremely difficult to do as a randomized trial. So this is what we're doing, and we're currently collecting the data. We have for the first year, we had the round we call 6 we done last year. We got 75% of follow-up, which is pretty good, but we still hope to do better, and we are working in order to try to contact trace those participants. And so this is our first aim. The second aim is that we will have enough power now, because we probably will triple the number of cases to look at this analysis by ethnic group, which was not possible the first time. So this is the epidemiology part of the study. We have also a psychology, biological, physiological part, because the idea is that whatever we found as an association of PTSD with CVD as an independent factor, a risk factor, or as a factor that is mediated, we should find the differences among participants. We should be able to measure those differences in risk factor according to the level of CVD, of PTSD. And so we are doing a sub-study with about 200 participants that are going to the lab of Dr. Flory and Yehuda, and are doing a whole set of tests in order to measure, their hormonal status and their cardiovascular risk factor in more detail. And we will separate. This group is actually sampled to be a non-PTSD, moderate PTSD, and chronic PTSD according to their history of PTSD. And we will try to confirm in this subgroup in physiopathological study the findings that we will have in the epidemiology study. You tell me about the time, because I'm not following with. Okay. So this is the model that is underlying the sub-study, and as you see, the idea is that you could have some dysregulation that will actually impact different factors that are not necessarily the classic conventional cardiovascular risk factor. All right, so in terms of outcome, we are still doing our active follow-up, but we have been already able to link the cohort to SPARCS again. So we have a second set of data. We have actually cumulative data from SPARCS that we are analyzing from 2012 to 2022. We linked the cohort to the National Death Index until 2022, and we have this sub-study. Okay. Yeah, let me introduce to you the band. So on the psychological drum section, we have Dr. Janine Flory and Rachel Yehuda. They're both co-investigator, and Marwan Al-Mansour, who is the study coordinator for the sub-study on the epidemiology brass section. We have Dr. Sonia Swanson and Dr. Leah Salzman. Dr. Swanson is at Pitt, and she's an expert in causal model, and Leah Salzman is at Tulane, and she is handling actually our databases and running most of the analysis. We have also a cardiovascular triangle epidemiology. This is Dr. Mauricio Trevisan, who works now in Rome. And finally, the Queen's College group which is on keyboard and guitar, comprises Paula Angel, who is our study coordinator, and Cassidy King, Dalia Abbas, and Niger Rocking, yeah. And so thank you very much. This is my presentation. I hope we have more time now to discuss these different elements.
I'd like to add for any questions, please raise your hand. We'll get the microphone to you, and that way the folks listening in online will be able to hear the question.
So while there may not be a lot of literature on PTSD and CVD, there is a fair amount of literature on hostility and anger and CVD. Do you believe that the mechanistic approach that you're showing will be the same or different when you look at emotional responses that are closely linked to PTSD, such as hostility and anger?
So thank you. We actually had an anger scale that we measured in the first at the first baseline, and we analyzed this data, and we didn't find anything. So that's why we haven't reported yet, and we haven't redone it again. But we did actually measure. It's very complicated to get a real good idea on epidemiologic studies about those questions, and but we tried.
So there's a strong association between PTSD and sleep apnea and sleep disturbance, duration of sleep and cardiovascular disease, and OSA and cardiovascular disease. So maybe all that you're seeing is the effects of sleep disturbance and sleep apnea. So do you have a...
I mean, as long as we cannot measure it, I mean, this is part of all the unmeasured factors that enter in our model. So we know there are all those unmeasured, but when you find systematic associations and when you can actually do it on a longitudinal base and use the causal model we are using, which with time varying, et cetera, your factor would need to vary along with those, which is almost impossible. So I think it's if this factor is extremely correlated with PTSD or something, we may never be able to separate it. But it would need to really track the time variance of the PTSD, and I don't know if this is possible.
So I'm just curious, in that subset study that you're doing at Sinai, and you're looking at sleep disturbance, I saw, are you doing sleep studies, or is it just qualitative?
No, it's not qualitative, but we are not doing it. Yeah, here you have Dr.
We're measuring the Pittsburgh sleep quality self-report. But we can also look at, we're getting medical information, and if people have, do have diagnosed sleep apnea, we can potentially look at that. But in terms of both anger and sleep disturbance, because we have, the full PTSD scale, we can also look at the clusters and those individual items to see whether there are different clusters that change over time that might be driving that association. But yeah, there's plenty of things we can do.
Thank you. There are several questions.
Yeah, I might have missed it, but did you do kind of like a clinical exam for PTSD? Did you have a clinician actually do you just used the PTSD scale. Did you have a clinical kind of evaluation on the PTSD?
So on the epidemiology part, we just use the PCL. But I would like just again, Janine to answer that, because in the sub-study, they do a clinical examination.
We're doing it by self-report. We'd actually proposed in a prior grant to use the caps, but the reviewer said
So I repeat what Janine said. We do it by self-report, but we tried in a previous grant to have a more clinical approach to it, but it didn't go through. Please.
Yeah, I have several points. One of them is that I didn't see any mention. Depression is very well established as a risk factor for cardiovascular disease, and it's extremely highly comorbid with PTSD in this population. In some subgroups that we
Speak closer, because I don't hear. You have to bring it very close to your mouth.
It's like eating an ice cream cone.
Yeah.
Hello?
Yeah. Bring it closer, or speak louder, or I come.
All right. So, you hear me?
No, just yell into it.
Yeah.
Maybe I can ask my question. It's a quick one. These pretty significant findings of PTSD. Do you think it's tied to World Trade Center PTSD, or is this, in other veterans and other groups as well?
So great. I can start answering, and I think this is another question for Janine, but we consider as World Trade Center as the common trigger for all the cohort of potential PTSD, but they may have a history that predated this, and Janine can say something about that.
Yeah.
Yeah, please.
Very interesting study, and we've been following your work for quite some time. Very complicated. I don't actually know how you're going to actually have significant results, because PTSD, actually, there's a ton of literature showing PTSD is correlated with coronary vascular disease. It's not new. And the problem that I see in separating all this out, and I would love to hear your comments because you're the expert, you know the data, but PTSD is also associated with every one of the factors that could be confounding this. PTSD is associated with hypertension. PTSD is associated with dietary obesity. So therefore it's probably associated with cholesterol. I haven't looked at that, but I know it's associated with the others. So how are you going to separate all this out and then throw in on top of that the fact that much of your data, of your confounders, is self-report? All right. So I just think it's a huge challenge.
Mm-hmm. Thank you. So that's what I've tried to explain, but I'm going to try again. So if you have only one measurement, one baseline, and one outcome, right? You have PTSD, you have cardiovascular risk factor. What you're saying, PTSD may be, its effect on cardiovascular disease may be mediated. So you have PTSD that brings people to smoke more, and because they smoke more. But this is one option. The other option is that PTSD would act on the cortex and the hormonal system and have its own independent effect. But when you have a single study with a single baseline, you cannot really separate exactly what you're saying, the confounding from the mediation. That's because they are extremely correlated. So we've added a second baseline. Now we have a baseline in 2012. We have a baseline in 2022. So now the relationship between PTSD and cardiovascular risk factor will be different between the two baselines because it will be just PTSD and the risk factor. And the impact of that relationship on the relationship of PTSD with cardiovascular disease is going to be more of a confounder. And so we'll have a situation. Sorry?
I'm not quite certain about that because you'll also have more time for PTSD to impact on the confounders. All right. So there'll be more time for PTSD to become more associated with hypertension and more associated with dietary cholesterol, et cetera.
Yeah, but you have two situations. One, I mean, analytically, is very different. And so you have to consider the relationship between PTSD and CVD in a situation in which you have two baseline assessment without outcome as different from the one in which you have an assessment of the risk factor and the outcome. That's how we separate that. The other way is that we look at trends. And when you look at trends, you are in a better situation to actually see whether the trends are related to the, are you still with me or? He's gone. So, no problem. Yeah.
Describe some of the analytical approaches you're going to be using in your work. Analytical statistical approaches.
Yeah. And so this is a question for Sonia. Where are you, Sonia? Yeah, please. She's the expert in causal model
great.
that I just described. So if she can have a microphone, she will answer. Yeah, thank you.
Okay. So just very briefly, I think like what the last answer was trying to get at was a little bit about how in this situation, we can really think of PTSD as a time-varying factor as well as having time-varying confounding. And the broad scope of our analytic plan is then we can embrace what's known as G methods, which are really designed to take into account that time-varying confounding structure. I'm happy to, be emailed about any specific questions on G methods if people want more detail than that.
Got another question. Thank you.
Thank you, Sonia. Thank you.
All right. Hey, Alfredo. Good talk. I had a question, sort of building off of one of the things you just said to David, which is that it's possible that you have that PTSD could cause more severe sort of pathways along the lines of normal CVD, or that it could cause a totally different pathway. So that seems kind of exciting to me. And I was wondering, do you have any evidence that the people with PTSD, that the risk factors are operating in some sort of different capacity, right? So like, is hypertension in someone with PTSD as predictive of further CVD as it would be in a normal population, that kind of thing?
Yeah, so that's, again, I think it's kind of a similar question. Thank you. The whole problem is to try to separate whether the strong correlation, because it exists, we know people with PTSD tend to smoke more, have high blood pressure, etc., have all those factors which may cause high risk of cardiovascular disease. So the question is the effect of PTSD strictly related through this pathway? So PTSD doesn't change the cortisol system, etc., and all the other hormonal mechanism that actually can cause, or inflammatory mechanisms that can cause arteriosclerosis. It's not that. It's strictly that is associated with conventional risk factor. And I think this is the common knowledge today, and that's why it's not recognized as such. What we're trying to do with our approach is to separate those two things, and that you mentioned, and that's the only way we can think of, besides doing a randomized controlled trial, which is not an option.
We have a couple more questions.
Yeah.
Robert?
Yeah, it's getting very interesting getting into your methods here, huh? So actually, my question is that my understanding is that you're taking the same cohort. You have one baseline early and a baseline later. So I was just thinking about the people in the early baseline that have a heart attack, early, and then so of course they're going to be removed from your cohort. So you have a different cohort, the baseline second time around. And then I was thinking that the early heart attacks related to PTSD may be different than the later heart attacks related to PTSD. So I just sort of wondering how I don't know exactly how, what I'm asking. It just seems to me you might have two different PTSD heart attack or cardiovascular disease relationships going on, early and later, plus you have some sort of survivor effect also.
Mm-hmm. Yeah, I mean, it's a good point, and probably we won't be able to address it, but that the cohort was very young. 10 years ago, they were in their 50s. Now they're in the 60s, and it's a time period where the risk for cardiovascular disease increases a lot. So in terms of number of cases, most of them will occur after the second baseline. And we had a few during the first. So we could also say, that when you have a heart attack, and they had quite, twice the risk of anyone in their age group in the 50s to have a heart attack in this cohort. So when you have a heart attack when you're 50, 55, maybe that's different from what you get when you're 60, 65. But our methods are going to look at the difference between the two periods among the same people. And so we try to disentangle the relationship of PTSD with the cardiovascular risk factor in two different contexts, one that leads to another baseline and one that leads to the outcome. So I think it's still valid, but your point is well taken, and I don't know if we'll be able to have an answer for that one.
Yeah, my comment was related to that depression
Yeah.
is very well established as a risk factor for cardiovascular disease, even better than PTSD. And it's also extremely highly comorbid with PTSD in this cohort. In some of these studies that subgroups that I have, up to 90% to the point that we gave up when even trying to separate the effect of both. So the other thing is that you obtain very detailed information about the metabolic syndrome, but presented no result out of it, which was something that I mentioned at the time years ago.
I remember you now.
I remember.
Yeah,
Exactly. And that is also a little bit time varying, but it tends to get worse. But on the other hand, it was not presented. And how do you play? What interplay does it have in the models? Is it a confounder, a mediator, etc.? So to make things more complicated and a little bit more nihilistic with regard to your models. By the same token, PTSD has trajectories, have been well established by research, and we actually made use of that when we correlated it with bronchodilator response, and it was extremely revealing at that point. But it can also be another factor to take into account. The other thing is that what is the weight of PTSD treatment for which you have data? Because this is a little bit of a captive population in that respect, because mental health services in the community are so poor or leave a lot of room for improvement. But it could be a mitigating effect on one end, but it can also be a worsening effect because some of those medications that are used in the pharmacotherapy of PTSD are change the lipid profile and increase weight. So there you go with another curveball. And the other one is whether you think there is a detection bias related to the, the nature of the cohort to begin with. And because we tend to detect very minor events, and also because of reporting due to PTSD itself.
So the last question is about the outcome, the cardiovascular disease?
Yeah, in that case.
Okay, so I have 5 points. I hope I'll remember the five. The first one was about depression.
Yeah.
We have a depression score as everybody knows, in the program, and that's what we used. It's worth what it's worth, but we tried to repeat the analysis, eliminating the people who had depression and PTSD. So we repeated the analysis only among the people who were had probable PTSD and not depression, and we found a very similar result. I showed them just before. The metabolic syndrome, let's start this conversation again. We should be able to do it in maybe better condition now. I'd be very happy to. The third one was about treatment. That was the first one. So treatment, that's a very good point. And we want to investigate if we can actually have the information for the PTSD participant, whether they were treated or not, since maybe we have the information in the health program. So that would be a very important point to add to the analysis. And the detection bias, frankly, I don't think this is a major issue here because, first of all, we are trying to validate all self-reports in medical charts, and the medical charts are reviewed by Dr. Trevisan, who is a cardiovascular epidemiologist, and myself, who has some MD background. I was an internal, I was certified in internal medicine, so I have some, and so we review all the charts and establish whether yes or no. So I don't think there is such an issue, and then when you look at the hospitalization, we look at discharge diagnosis, so, but we can never exclude that. And I think I covered all your points. Thank you.
All right. Hi, everyone. My name is Emma Butterini. I'm an epidemiologist on the research team with the program, and I have the pleasure of introducing our next speaker today. So we have Dr. Susan Titelbaum. She's a professor and director in the Division of Environmental Epidemiology, the Department of Environmental Medicine and Climate Science at the Icahn School of Medicine at Mount Sinai, and she's the deputy director of the World Trade Center Health Program General Responder Data Center that manages and analyzes the big data repository of exposure and health-related data for more than 45,000 WTC General Responders.
First of all, I want to thank Dr. Brackbill for giving all of that wonderful biological background on why World Trade Center exposure may be related to cardiovascular disease, because I hoped somebody would. I didn't include it in my presentation. So first and foremost, this paper, because basically my talk is based on a paper that we published, was because of a great group of people, both related to the data center, our data analysis team, as well as the clinical centers of excellence who work so hard to have the responders complete their monitoring visits. So first, let me give you some background. As we know and we've heard, heart disease continues to be a leading cause of death worldwide. And major cardiovascular disease risk factors include age and smoking, diet, obesity, hypertension, high cholesterol, diabetes, and psychosocial stress. So more than 90,000 World Trade Center disaster responders were exposed to toxic substances and also stress. And research has shown that these exposures are associated with many World Trade Center related conditions, respiratory disease, GERD, PTSD, and some cancers. So the goal of our investigation was to examine the association between World Trade Center related exposures with cardiovascular disease risk over a 17-year follow-up period of the World Trade Center Health Program General Responder Cohort. So let's define our outcomes. Our cases. Cases were defined as responders who, at a monitoring visit, reported a first-time physician diagnosis of coronary artery disease, myocardial infarction, stroke, and/or congestive heart failure. And that had to have occurred after 9/11/2001. All responders who reported cardiovascular outcomes that were diagnosed before 9/11/2001 were excluded from these analyses. And if a responder only reported a heart murmur or other heart disease, they were considered not to have cardiovascular disease and were included in the control group. So exposure, big deal. We used an exposure variable that was based on self-report that were of both the arrival date and the cloud exposure on 9/11. If a responder arrived on the site on 9/11 and was directly exposed to the dust cloud, they were classified as having a very high exposure. If a responder arrived on 9/11 but was not in the dust cloud, they were considered to have high exposure. And then the comparison group were the low intermediate exposed responders, and their arrival was on or after 9/12. So the next consideration in our analysis was the time period of the follow-up. Periodic health monitoring by the World Trade Center Health Program, it's generally a 12 to 18-month interval, was initiated in July of 2002. The general responder cohort, as opposed to some of the other cohorts that you're going to be hearing about, is an open cohort. And so members continue to enroll in the program. For this analysis, we used information that was collected through the end of March 2019. And to be included, the analyses were performed on data for responders who provided consent to have their data used in research and responders who provided responses to questions about physicians' diagnosis or treatment of cardiovascular disease. In total, 37,725 responders were included in this investigation. So, our statistical analyses, pretty straightforward. To estimate the risk of cardiovascular disease, we used a Cox proportional hazard model. And we used age, because age is a risk factor, we used age as the time scale. And this is similar to the approach that the FDNY used. We had a follow-up interval that started at the responder's age on 9/11/2001, and it ended at the age of diagnosis at the earliest primary event. And for controls, censoring was at the age of their last monitoring visit. The longest follow-up that we had was approximately 17 years. And in our analyses, we conducted overall and sex-specific analyses that were adjusted for covariates that are known cardiovascular risk factors. We also conducted sensitivity analyses and also evaluated for recall bias. So let's get into the meat of this. These graphs represent a selection of the general responder cohort characteristics. On 9/11, the median responder age was 37 years, and the age range was from 19 to 80. But most responders were between the ages of 30 and 59. So 86% of the general responder population were men, and the majority of the population reported their race ethnicity as non-Hispanic white. When we considered the three levels of WTC exposure, a little over half of the responders arrived on or after September 11th, and they were categorized as the low intermediate exposure level. 35% of the responders arrived on the site on 9/11, and more than half of those were exposed to the dust cloud. Most of the responders were married. They never smoked cigarettes. They were quite obese or overweight, 80% of them. Over half of the responders were diagnosed with high cholesterol, and over 40% were diagnosed with hypertension. And 50% of the responders enrolled in the program before 2008. And here are the stats on the cardiovascular disease prevalence. A little over 6% of the general responders reported having been diagnosed or treated for the first time. More than half reported cardiovascular disease as coronary artery disease. It was followed by stroke, myocardial infarction, and congestive heart failure. There was only 0.7% that had congestive heart failure. While the prevalence of post 9/11 stroke and congestive heart failure were similar among the males and the female responders, the prevalence of coronary artery disease The prevalence of coronary artery disease and myocardial infarction among men were 3 times more than women. And the mean age of cardiovascular disease was 52 years, and it occurred an average of 8 years after 9/11. The age and years since 9/11 at diagnosis did not vary by sex, and there was also little variation in the age at diagnosis for the cardiovascular conditions. All right, so this is a visual depiction of the distribution of the post 9/11 cardiovascular disease. Some cardiovascular disease comorbidity was observed, as you can see on the Venn diagram in the intersection. Considerable percentage were diagnosed with coronary artery disease and also reported heart attacks, stroke, and congestive heart failure. And a small percentage actually reported 3 or more of the cardiovascular diseases. So here we go. Cardiovascular disease risk and World Trade Center related exposure. So the adjusted risk of cardiovascular disease in men was substantially higher in the 9/11 arrivals that were not exposed to the dust cloud. It was an HR of 1.43, and those exposed to the dust cloud was an HR of 1.4. And that was greater than the general responders that arrived on 9/12 or after. Among the women, the adjusted HRs were 1.59 for those arriving on 9/11 with no dust cloud exposure, and 2.16 for those arriving with dust cloud exposure compared to the women who arrived on or after 9/12. One of the things that we did notice was the distribution of occupation among the responders, and a great proportion of the responders' occupation on 9/10, we asked about occupation on the day before the attack, were in protective services. So we additionally adjusted for being your occupation being in protective services. And although it attenuated being in protective services was definitely associated with increased risk of cardiovascular disease in both men and women. But with the adjustment, it attenuated but did not eliminate the effect of World Trade Center exposure in those that arrived on 9/11 in the dust cloud. So overall, we found higher risks of cardiovascular disease in 9/11 exposures compared to those who arrived on 9/12 or after. and it's consistent with the fire department and the registry results. The employment in protective services was associated with cardiovascular disease, but it attenuated but did not eliminate World Trade Center exposure risk. And we also did an interaction assessment and did not find a significant interaction between arrival on 9/11 and being in the protective service occupation. So they were independent of each other. Associations of known cardiovascular disease risk factors were included as covariates, and all of the association between these covariates and cardiovascular disease were in the expected direction. The interesting thing is that cardiovascular disease may be occurring at younger ages than expected. The World Trade Center GRC's average age at heart attack was 52 years, but in the US population, the average age at heart attack is 64 for men and 70 for women. So of course, as every epidemiologist must tell you, there are potential limitations to this analysis. First of all, and we heard a lot about this already, the validity of self-reported cardiovascular disease is imperfect. Effects may have been spuriously increased due to possible inaccuracy of cardiovascular classification, and the exact date of cardiovascular events were not always recalled. And depending on the available information in our analyses, we either imputed the date or the event itself was eliminated. We also classified heart murmur and other heart disease as non-cases, and so that comparing high to low exposure may have attenuated the associations. But there's probably more work that can be done, and these are some of our suggestions for future research to be done. And we've heard about this already. Obtaining electronic health record data on the responders' cardiovascular health to validate the self-reported diagnoses would be strengthening to the analyses. And then, I haven't actually, in all of the presentations, diet and exercise are some of the big cardiovascular disease risk factors. We don't collect information on that in the monitoring visits, and so it would be really useful information in order to better understand cardiovascular disease overall in the cohort. And additionally, getting family history of cardiovascular disease might be useful. When I had made these slides, I said we should consider a pooled analysis of cardiovascular disease incidence across the three groups, the general responders, FDNY, and registry cohort. And I know that it's been funded. And so it'll be really great to be able to get the power of having those three cohorts together to see what the outcome is with respect to World Trade Center exposure. And then finally, and we also heard a lot about this, is investigating post 9/11 air pollution exposures as potential effect modifiers of the cardiovascular disease risk and World Trade Center related exposures. We are doing some work at Mount Sinai with respect to that. There was a paper published by Noble et al. About looking at air pollution with cardiometabolic clinical measures. And there is more research going on to look at whether or not air pollution experienced after World Trade Center may have mediating or an additive effect to the exposures from working at the World Trade Center. So, acknowledgements, always critical. We have to thank the World Trade Center Health Program and the data center staff, the labor, community, and volunteer organizations who are stakeholders, and the general responder cohort themselves for generously giving of themselves in the response and providing us with all the monitoring data information that we use in order to do these analyses. And of course, we cannot ignore our funders. This study was supported by a grant from CDC and, well, they're actually not a grant sponsor, but contract, and through cooperative agreements and contracts to all of the clinical centers of excellence. Thank you.
Thank you.
No problem.
Really interesting. I'm probably the guilty person who told the fire department to look at age as a time scale in Cox models, which is absolutely, I believe, what one should be doing if one is interested in addressing age as a confounder, and it is certainly a major risk factor. But there is an advantage in looking at time from exposure, in that you can potentially look at how the hazard ratio might change over time, and whether the effect is diminishing or might even be increasing. Have you looked at that, or any of the other researchers looked at that?
I'm looking to Nancy Sloan, who's in the audience right there. She's the first author on this paper, and she oversaw all of the analyses.
Yeah, we also looked at risk over time, which was increasing.
Increasing, interesting. Usually, a short-term exposure
Would
results
diminish,
in a diminishing over time.
Yeah.
So that's a real shocker compared to other things. And the other thing I will mention is I'm a big fan of air pollution research, and I'm collecting air pollution data right now and doing this in a study. The air pollution in New York City has declined over the past 20 years or so. At least the outdoor air pollution has.
Yeah.
We're actually finding a lot of indoor air pollution, and that might be, it's harder to work at, but we do have technology to do that.
So we have a whole group of air pollution modelers in our department who use satellite modeling in order to do very fine grained assessment of, I think it's hourly air pollution levels. Obviously this is their life's work. And so one of the members of that group has a grant and is working on the air pollution related to cardiovascular disease in the responders. So they're like, it's their god of air pollution there.
It's great. The only problem with that is that gets the outdoor air pollution really well. It doesn't do the indoor. And I'll tell you that I've been finding shocking levels in the New York City subways.
Oh, I'm not surprised. Wow.
But anyway, that's for a future work.
Yes, thank you for your presentation. In light of the two previous presentations, I just wondered, PTSD, is that something that you've looked at also?
We actually, we did not include it in our models, and we have not examined, remember, we're the superset of Alfredo's cohort is selected from our whole general responder cohort. But it's definitely, after hearing the presentation, Nancy and I were discussing it, so.
Thank you, Susan. Just when you say the risk was higher in women, you mean the relative risk, right?
I'm sorry?
When you said in your conclusion that the risk was higher in women, you mean the hazard ratios, right?
The hazard ratio, yes.
Yeah, because with
you're right.
Since the baseline is much lower, you would expect a little bit that.
Yeah.
And so what do you do with the fact that you're dealing with prevalence? And not, I mean, because you are asking survivors, right?
No, it was incident. The first, if any cardiovascular disease was reported prior to 9/11, they were excluded from the analysis. So these were incident cases after 9/11.
So they were reported in the visits.
At the visits, yes.
Okay.
Yes. At each monitoring visit, there's a cardiovascular related question section, and they're asked if a physician has told them, or and we asked for the date of that diagnosis. That's where the date was sometimes a problem with respect to exactness. So we did have to impute at times, but we did know that, like the monitoring visit before, it was not reported. So
I got it.
Yeah.
Thank you.
No problem.
Robert?
Okay, nice talk. Thank you. Yeah, so actually my question is, I was just looking back, and you didn't look at, or did you look at angina as an outcome? I mean, you had the list. Angina, I mean, is something that showed up in the registry kind of early on. I think Jim Cohn, Dr. Cohn said he looked at that.
Yeah,
early
we
on.
don't
Yeah.
we don't have that.
Thanks for your presentation. Could you clarify the difference between a protective role and a non-protective role in the risk?
Oh, protective services, you mean?
Protective services,
So
yeah.
it's security, police department, those are protective services. Military,
Did you have a sense as to what contributed to that risk?
I'm sorry?
Do you have a sense as to what contributes to that risk?
I'm going to end up building a little bit on that. The occupational risk I found interesting, in part because, at least in our experience, PTSD in that group is lower.
Yeah.
And so it goes counter to a lot of the different descriptions of the PTSD as a risk factor. So I was going to ask a very similar question.
Do you have a response or you want a question?
The other thing is that many of these police officers have reached retirement age after 20 years of service, plus the overtime that they accrued at the sites. So many of them have had cardiac stress tests done. And we also had a screening study done by Dr. McLaughlin at Mount Sinai. Yes, that increased the detection of many cases. And on the other side, we have the effect that was just mentioned, or potential effect, mitigating one, in that they have less PTSD, and their trajectories are different for PTSD. So it's a complicated issue, but one that I didn't hear in the previous presentations. So thank you for having done it. At least it started.
I was just going to comment on that group. Sometimes when they're working, they don't report PTSD,
Right.
even though they have it, because they might not recognize it, or they might be suppressing it because they'd lose their jobs.
Yeah, I was going to mention. I've been told that that is
Like when
one
they retire,
situation.
that's when they
Yeah.
notice the symptoms coming up.
Okay. Thank you.